both the facet joints, the costovertebral, the costotransverse joints, the relationship of the movement of the ribs to the scapula, and then relative to the whole upper limb movement. So stiffness or dysfunction at the thoracic spine or stiffness at the thoracic spine has the potential to have shoulder load or dysfunction follow on. But the victim is the shoulder, the culprit is the thoracic spine. So for example, if I have a thrower who is having maybe a long-headed biceps tendon pain, and they're having pain coming up into a cocking position and it hurts here. This part is being compressed and giving pain, but the reason for the problem is they're not able to get their shoulder blade retracted enough, or they're not able to extend through their thoracic spine or rotate enough through their thoracic spine, so they're getting more load through the shoulder. Where we want the rotation and the extension is in their thoracic spine, not extra load at the shoulder joint. Does that make sense? So just thinking about an anatomical proximity and how that kinetic chain works together to present as a shoulder problem, where there is potential that treatment of the thoracic spine will resolve that. And posteriorly, again, thinking about the soft tissues, looking at that large and also the laxness of the inferior glenohumeral ligament, the bursae again, and now then if we add infraspinatus, supraspinatus and teres minor. Now again, we know that the infraspinatus and teres minor externally rotate the shoulder. However, they are most active in flexion positions because their role is to stabilise the back of the shoulder. So when the arm goes up into flexion, then the posterior cuff, the infraspinatus and the teres minor, are active to support the humeral head posteriorly, so it doesn't just drop out the back. So if you again want to work infraspinatus, you can do flexion, overhead, weight-bearing type positions that push the humeral head posteriorly and make the infraspinatus work to stabilise it and reinforce the back of the shoulder. Now, I've taken the infraspinatus off and we're looking at the neurovascular from the posterior aspect. And I just want you to notice the suprascapular nerve there. So the suprascapular nerve is the yellow that runs around the spinoglenoid notch here and can be compressed here. Now the difficulty with this nerve, it does not have a sensory component. There's no loss of sensation when it is compromised. There is only loss of muscle strength. It is a motor nerve only. So it is a motor nerve to supraspinatus and infraspinatus, but if it's compressed at this point, you will have loss of infraspinatus function. And that may present as weakness initially. Later, it will present as atrophy, so it will start to hollow through the back there and lose that. Commonly seen in people who have had a dislocation and have a paralabral cyst compressing the spinoglenoid notch, or in overhead athletes where they're lacking upward rotation of their scapula, and that suprascapular nerve is compressed at the spinoglenoid notch in overhead positions.
Is that an anterior luxation or posterior luxation?
It could be either, but you would be thinking more posterior, with the posterior labral. Now let's talk about impingement. So as a concept, let's talk about it from an anatomical point of view. So firstly, with impingement, it is classically described that when the arm comes up into abduction, the supraspinatus compresses against the coracoid and the coracoacromial arch. the acromion and the coracoidocromial arch with the ligament here. So your coracoidocromial ligament here. That compression is thought to be a pathological condition. But what we know is that everybody in this room, as you lift your arm up overhead, those structures are compressed. And it's a non-painful compression. So in the normal population, it is normal to have compression through abduction and flexion movements overhead. It is non-painful, and it's not a pathology. Secondly, the radiological reports will often talk about a type 1, 2, 3 acromion. Do you have that in your X-ray reports and your MRI reports? So they're talking about a bony spur from the acromion, which is thought to push down and push into the supraspinatus, so creating like a little tear. So if the tendon's going through there and the acromion spur comes down and rubs this way and creates tears. So firstly, we know from the shape of the coracoacromial ligament, we talked about it being more wide at the bottom, narrow at the top. Because the humeral head normally just moves when we move, it creates tension in this coracoacromial ligament. That's a normal response. In some of us, there is a bony response from the acromion, and it creates a little bony spur. So it's like in your plantar fascia, where you have a calcaneal spur. The spur is contained inside the plantar fascia, and it's the same here. The spur is contained inside that ligament, so it doesn't hook down and push into there. We also know that two-thirds to three-quarters of rotator cuff tears are on the undersurface of the supraspinatus. So they are not on the top. So the acromion is not doing this. There's some process underneath which is creating rotator cuff tears. So the concept of the spur being part of the problem of impingement is flawed. And that's probably stemming from originally we would investigate shoulders with X-ray, and you can't see the ligament, so you can't tell that. That has been a more recent development. And if you've ever gone in and watched shoulder surgery and watched arthroscopic surgery, it's not very clear where all of the different structures are. The spur is contained within that ligament. There's also a comment around impingement related to the bursa. So I've already said the bursa itself, the subacromial bursa, subdeltoid bursa, is a very strong source of pain. One of the, where I live in Perth, we have an open water swimming race which goes from the beach in Cottesloe to Rottnest Island, which is a small island off the coast, which is 19.7 kilometres the distance of the swim. And people do this in teams of 4, they do it in pairs, and they do it as solo swimmers. And each year people start to train for this event in February, and then the event is in late February. So one of our sports doctors decided that he was going to do regular ultrasound checks on swimmers who were training for the Rottnest swim to look at the size of the bursa in their shoulder. And what he found with all of these, and all of them had no shoulder pain. So then all of them started doing their swimming training, and their bursa got a little bit thicker, seemed to respond to the load, got a little bit thicker, but no pain. Then they go into the swim, and afterwards, some of them had shoulder pain, some of them didn't. They did the ultrasound again, and most of them had an increase in size in their bursa. The ones that had the biggest increase were the ones that had shoulder pain. But what he was seeing was that the thickness of the bursa, it was on a scale. Everybody had changes to their bursa. They seemed to respond to the swimming load over the training course and over the event, but only some of them that the bursa got thick enough that it created shoulder pain. So generally, the bursa will respond to a load. It may or may not be a source of pain, but if it's very big, it's more likely to be contributing to that shoulder pain presentation. And the reason that I bring this up is that every MRI, bar except a few, most MRIs that I see will come back with a degree of bursitis. And so the first line of management by the doctors often is straight into an injection. And that may be helpful, but it may not be. It may not even be part of their pain picture. So just to have awareness that there are normal changes in the body that fluctuate up and down in response to load. Sometimes they are painful, sometimes they're not. And we need to use our clinical decision making, and we'll talk about this more, as to how would you decide that this is an appropriate course of action to go towards an injection for a bursitis, for example. But essentially the concept of impingement by itself doesn't really stand with what we know around modern pathology, imaging, our understanding of tendinopathy and subacromial pain and rotator cuff related pain. So we'll delve into more and more of that as we keep on going.
So you are going to Paris?
Yes, I am.
So you have, of course, we have the patients that is calm down, it's relaxed, but that won't be the case for your patients in Paris. They will say, my bursa might be bigger, but I have to get a medal.
Yes.
So what are you going to do for those patients?
So yes, again, it's a very difficult thing because they want to be better yesterday.
Yeah.
And there is in that scenario, there's a very clear time frame. And working with the sports doctors, and if they have signs of an inflammatory process that's non-responsive to an oral medication, the sports doctor probably will inject them because they want to give them the short-term relief that you get from cortisone.
Yeah.
And the time frame for cortisone, which again we'll talk about more, but it gives you a very good short-term relief of pain if that's where your symptoms are coming from. Yeah. And even with that elite level athlete, we want to, before heading down that pathway, we want to know that that is at least partially the source of their pain. If they don't fit that, then we know that that injection is not going to help them. So they won't tend to do that. And also, with the rules, there's timing of when you can have an injection also. And there are negative effects to injection too, so their history is really important. Yeah. So it's not straightforward, is it? Okay, so this is why shoulders are so difficult. It's a very complicated anatomical joint, multiple overlapping structures, many potential sources of pain, and it's very difficult to isolate one source of pain around the shoulder. So we have many different sources, and what we want to try and do, beginning with our subjective questioning, is to start to unravel where could that shoulder pain be coming from. Now, obviously, there are things like red flag presentations, cervical spine referral. That is not going to be the focus of what we talk about today. Obviously, I want you and need you to have an awareness of those things, and we will touch on them, but it is not the focus of what we're going to do over the next 2 days around the shoulder. So we need to start with our clinical reasoning. We need to have this as clear in our head as we possibly can. We want to try and come up with a diagnosis. We want to rule out what the problem is not. And that can be as important as deciding, yes, this potentially could be contributing to the shoulder presentation, but it is also important to rule out what is sound and strong and clear from a structural point of view around the shoulder. We want to know what the problem is. So what are the clinical features that are contributing to that diagnosis, and all of the factors that are contributing to that patient's presentation. I've added this, not that because we're specifically going to speak to this, but it gives us a good framework of how to arrange your clinical reasoning. This is the clinical translation framework that we use at Curtin University. It gives us some structure on the questions and the domains that we need to consider when we're doing our assessment, and some structure to our subjective. So I'll just acknowledge the authors from Curtin University: Tim Mitchell, Darren Beals, Helen Slater, Peter O'Sullivan, who put together this framework. And it is available online. I think it's an ebook, but we'll talk to the different domains as we go through. So from the point of view of asking, it's really important to establish what the patient's problem is, what they're able to do, what they're not able to do, but also, I cannot stress enough, what do they want to get out of the appointment that they're coming to see you, particularly if they're any patient, but if they're a private patient and your role is to establish a rapport with them very quickly, then you need to know why are they coming to see you and what they want to get out of that appointment with you today. They may say something that is completely separate. I've had more than a few clients say to me, I just wanted to know whether it was cancer or not. They had a real worry in their head, which I never would have known, because to me it seemed like a fairly straightforward shoulder problem, but they worried that they had cancer because their shoulder was aching at night. We're looking for a diagnosis. Now, I just want to highlight the difference between a specific and non-specific diagnosis. A specific diagnosis is something that if you treat that one thing, you are likely to get a complete resolution of their problem. For example, if someone has broken their arm, fractured their humerus, then if you treat that fracture, you are treating the problem. So very black and white. Non-specific diagnosis means there are potentially multiple sources of pain. It doesn't mean that you can't provide some clinical reasoning around potentially the relative contribution of multiple sources of pain, but if you only treat one component of that, then you're unlikely to get complete resolution of their symptoms. So for example, if I go back to that example with the biceps tendinopathy pain, anterior shoulder pain, for example, we have a biceps tendinopathy. But if I treat only the biceps tendinopathy, and I think I'm doing an amazing job of doing that, but they're not getting better, the reason is they also have factors like thoracic stiffness, which is contributing to their symptoms. So there may be someone the person may also have a bursitis that is part of that condition as well. They may have a rotator cuff tear related to that. And these factors all feed into that clinical presentation. I am not a fan of telling someone that they have non-specific shoulder pain, because I believe that sounds like you don't know what you're talking about. I would like to reframe that for you and say we have shoulder pain which has contributions from your biceps tendon, your thoracic, and I think your bursa is also inflamed. So we're going to work on treating each of these components for a whole clinical picture. Now obviously we need to be aware of red flags around the shoulder too. So red flags around the shoulder may be things like tumours in the lungs, for example, tumours in the bone structure here. So they're the key things to think about there. Oh, and sorry. And thinking about where they are in their staging. Is it an acute presentation? Is it subacute, so beginning to move on from that first couple of weeks? Have they had this problem before, or have they had it for an extended period of time, 6 months, couple of years? Pain features, think about the types of pain that you might see. So nociceptive is your mechanical pain, your chemical pain, thermal pain. So stimulation of the pain fibres. Neuropathic is a direct lesion or injury to the peripheral nervous system. And nociplastic is dysfunction of the pain processing of the central nervous system. So that, for example, with nociplastic might include things like fibromyalgia. Characteristics, mechanical, non-mechanical. So mechanical is if I move my arm in this direction it hurts, if I take it out of that position it doesn't hurt anymore. Non-mechanical, it hurts at rest, it throbs, it aches. I don't have to do anything, I'm sitting here listening to this and my shoulder's aching. That's non-mechanical pain. And in the shoulder that might get you thinking, okay, there's some sort of inflammatory, maybe the bursa is part of this problem. Sensitisation, how easily is their pain provoked? Now you need to be thinking about that because we're going to be doing assessment and we need to know how hard we can push, how much we can do. If someone says to you, I do this much, I do a very small amount of activity, my shoulder kills me, then you're going to try and tighten your assessment, your physical assessment, to the very key things that you need to do and save other components for a later date. Cognitive factors, what are their beliefs around their shoulder? Affective factors, are their mood, depression, anxiety, how worried about this condition are you, how is it affecting you? And social factors, what is their family support, what is their employment situation, what is the stresses in their life? Work considerations, blue and black. So blue is their workplace conditions and whether they like work and they enjoy going there or they'd rather be off work. Black is the pure task of the work. Is it a high demand job for, and we're talking about shoulders, is it a high demand job for shoulders or is it a low demand, they work at a desk on a computer, low demand for their shoulders. Lifestyle considerations and whole person considerations. Do they smoke? Do they exercise? Do they have other health conditions that contribute to their presentation? Screening for past history of injuries, screening for other health conditions, what medications are they on? And in the end, we're looking at their functional behaviours. Do they do things with their shoulder that are helpful to their recovery, or do they do things that inhibit and impair their recovery with unhelpful behaviours? And is it an impairment of movement, control? Is there something about what they're doing that is related to their pain? Or are they just weak because they're not using it anymore, because they're worried about it? At the end, which is what I'm going to be challenging you for, is what is your diagnosis, where are we at with the stage of their condition, and what are the important contributing factors? And it's that final part that's going to be able to help you decide what your management plan is moving forward. So, your assessment of someone really starts when they walk into your clinic and you see them and they say, I've come here for a shoulder problem. So you will get different clinical presentations in different age groups. And if the clinical presentation doesn't align with their age group, there's something a little bit wrong in their presentation. Maybe there's something in the background that's driving this, like a systemic inflammatory disorder or some other condition that needs to be identified, reviewed, managed in a different way. So let's talk about what we're most likely to see. So we're talking about shoulders. If you had this young boy coming into your clinic, I have a sore shoulder, what would you be looking for? What conditions could he present with?
Good.
Yes, so he may have a loss of range. What might that relate to why might he have shoulder pain there?
Because of his specific sport.
Yeah, related to the sport. And often in this age group, so we do talk about GERD maybe in this sort of age group, in the older age group, in this end, often it's the other end of the spectrum. Instead of loss of movement, what have we got? Increased movement, so hypermobility, instability. We know, first of all, skeletally immature, their muscle isn't developed, so they're not as strong as they are going to be here. Their technique often isn't very good, so they have poor technique, which predisposes them to instability presentations. What else might we see with these guys?
Constant overloading.
Sorry, what was that?
Constant overloading.
Yeah, constant overloading. So how might that present in this age group?
Because of sarcopenia due to age.
Sorry,
Due to sarcopenia of age.
sarcopenia. Yeah, so you obviously, if you have a young person coming in with significant shoulder pain, you definitely need to be screening for those red flags. And it may be a case that this is someone that you might send for imaging earlier than someone down who plays tennis and has come on with a shoulder pain, who is older. So anything with the red flag sort of presentation may. If we go back to the overload discussion, how does that present in someone in this age group?
Tendinitis.
Sometimes, but remembering their tendons are not the most vulnerable part, where else along the tendon might you see some pain?
Bone?
Sorry?
Along the bone?
At the attachment. So it's an apophysitis. So it's the traction. So in this age group, an apophysitis, very often at the elbow. So you'll get a medial elbow apophysitis. Around the shoulder, probably tendon in this age group is less common. What about their bony structure? So that's obviously still developing. And around the proximal humerus, we've got a physis, growth plate, that if you have repeated torsional movements, you can have physial stress. You can have physial stress fractures. So that can be a source of arm pain. Even in older tennis players, so late teens, early 20s, still might get a physial stress, bone stress through here. So generally with younger presentations, they're not as common. So if you do see someone, a young child who has shoulder pain, and particularly if they don't have a history of a lot of sporting load, you really need to be thinking about those red flags, clear them off early. Secondly, if you do have a young person with shoulder pain, it is more likely to be an instability type presentation or growth plate related presentation. So then if we go a bit older, we'll come to this group here. Maybe we'll go to this fellow here, the swimmer. What are you going to see for him? What are swimmers generally? Like, what's their body type generally? Sorry? Yeah, mesomorphic. So he has a lot of muscle, but what about his shoulder range? Yeah, tends to be hypermobile. So they can, if you treat swimmers at all, I can't even demonstrate, they can do things with their shoulders that I just can't do. They can abduct their elbow to their ear in internal rotation. They have a lot of range of movement. So it can be an instability presentation that may present as a rotator cuff tendinopathy because the rotator cuff is working so hard to try and control the joint underneath, which is the unstable, and that's the cause of the problem, with insufficient rotator cuff strength over the top to hold it together. What else might you see there? thoracic position, yeah. So again, you might have kinetic chain considerations with lack of movement through the thoracic spine, increasing the load. You also have load management conditions, so we're talking about a tendinopathy, again related to overload rather than instability. So that's the sort of presentation you'll see there. Then if you come into your overhead or your throwing sports, what would you see that is different to these ones here?
Is it more muscle?
Yeah, so more muscular types injury, your GERD, your loss of range there, more muscular presentations. Again, rotator cuff, clearly along the lines of the tendinopathy. Acromioclavicular joint presentations as well, being an overhead sport, thinking about those types of things. Slap lesions for the long head of bicep. So starting to think about different sort of presentations there. So this fellow here, younger, manual labourer, high load through his shoulder, what might you start to see here? So he can still have instability presentations, obviously, but that's, how is he different? It's more likely to be he's a manual worker, higher load through his muscles. What might you see then? Bursa? Yes. What else?
Imbalance.
Sorry, what's
Muscle imbalance.
that? Muscle imbalance, yes. Yeah. And that might present as a tendinopathy presentation, or subacromial pain syndrome, rotator cuff related shoulder pain. However, which terminology? We're going to stick with rotator cuff related shoulder pain. I know it's longer, but that's the one that I tend to use. Acromioclavicular joint, he does lots of lifting, carrying, loading through his arms. Distal clavicle osteolysis with excessive load. But then how does that contrast to the older man here? What might you see more in an older population? Arthritis, beginning of glenohumeral joint arthritis, AC joint arthritis, yeah? Anything else? So in this, yes, yeah, tears. So your rotator cuff is going to stress or react in the capacity that it has at the time. So the weakest point in a younger athlete is growth of bones and the attachment of tendon onto bone, that transition there. So an apophysitis. As you get older, the rotator cuff response to that load gets thicker, it becomes overloaded, but it tends to be fairly solid structure, and the apophysis is now solidified and matured. So now the tendon itself reacts. Then when you get into the older population, still starting down here but morphing into here, that's becoming more into rotator cuff tears, so that the tendon becomes more prone to failure in point. So it can be partial thickness, it can be full thickness tears. You can also have injuries to the labrum, you can have injuries to the attachment of the long head of biceps within the shoulder. But just to demonstrate along the lifespan and along sporting, different sporting activities and requirements, there will be different types of presentations, and that should align with the age as well as the activity of the person. And if it doesn't, then you need to reconsider what's going on. And it's more likely to be something unusual. So now we're going to, we've looked at them, we've got a bit of an idea of shoulder pain, okay, we think this might be going on. Subjectively, questions that we need to ask them. First of all, as we've just discussed, age is important because age aligns with different clinical conditions, pathologies, and where the most likely stress on the shoulder or the rotator cuff is going to be. What is their occupation? So you need to know the physical demands. Ask a lot of questions about their work. If you don't understand their job or their sport, ask them to demonstrate or to take some videos of their workplace for you, so you can get a better idea of what the demands of their work are for me. And I've had people do that, with certain tasks they have to do at work. Either describe it or they can take some video and show me next time. If someone says they just sit at a desk, you want to know the proportion of time they spend sitting at the desk, or do they spend some time moving around? Is that part of the problem? We want to know their regular physical activity and has there been any changes to that. Why do we want to know that?
There's an increase in frequency of training.
Yeah. Or a decrease and then back to their normal. So a very easy example of that is if you have someone who plays a seasonal sport, for example, and they come into you and they say, I play tennis 3 times a week. My shoulder's been bothering me for the last 3 weeks. So it makes it sound like they always play tennis 3 times a week. But it may be that they didn't play tennis last season. They've had 6 months of not playing tennis. They haven't gone to the gym and they haven't kept up any regular load of that type through their shoulder for the last 6 months. They've been playing tennis for 6 weeks and now 3 weeks into it, the shoulder has responded to that change in load. Or it may be they play tennis 3 times a week but they've taken on coaching and they're doing extra sessions and they're working specifically on their serve. And their serve is something they're trying to put more power into, so they're getting more load on their shoulder. So it can be a decrease and then back to what is usual load, or it may be an increase from their usual load. Ask what their symptoms are. As we've discussed in these presentations, it doesn't always have to be pain. It may be that it's a loss of power, so they're weak in their shoulder. It may be that they can't lift anything above their head. They can't get the movement. It may be that their shoulder feels unstable and it clunks. Usually their reason to come and see you is associated with pain. Usually it's pain plus something else. But the something else is going to be the thing that's going to help direct your clinical reasoning and the cause of the problem for them. We want a clear description of their symptoms. So by that, we're talking about how does it act in different situations, the type of pain that they get. So we're listening for things like nerve descriptors, so it's shooting pain. We're listening or lightning or burning or sharp. We're thinking of listening for things around ache, resting pain, it hurts at night time. That gives you descriptors around inflammatory process, so you're starting to think of whether it's a systemic rheumatological condition. Could it be a frozen shoulder? Could it be a bursitis? And we're thinking about when I do this, it hurts. When I don't do that, it doesn't hurt. So it is that on-off presentation that as physios we quite like, because that's what we can do a lot. Be very clear in your initial assessment. Your body chart, we want to map that body chart really well. So where is their pain or the symptoms? Are there multiple areas or is it localised? Does one lead to another, or are they two very separate areas of pain and have no relationship to each other? Very important that you map that early. We want to know their level of pain. What is their pain at rest? What is their pain with activity? What is their pain at its worst and what brings that on? So if someone says to me, I have a constant 2 out of 10 pain, it's always there, but then when I lift my arm overhead and put load in it, it goes up to a 6 out of 10. And then I might bring my arm back down and it's back down to 2 or 3 out of 10. So to me, that sounds like there's two different types of pain going on. There's a constant, potentially inflammatory pain, and there's a secondary mechanical pain, which is an on-off type pain. So more information about what could be going on with it. How did the pain start? Was it traumatic, or did it come on gradually? Was there one moment in time where this started, and what was the reason? So why are we asking about that? Why do we want to know about that moment in time that it started? And what are you thinking? If it started suddenly, what are you thinking about the cause of pain? Trauma to... So if something starts all of a sudden, is that a tendinopathy? Is that a fracture? Potentially. So what we're weighing up, is there a sudden onset of pain, or is it which would indicate some structural, generally, tear, damage? So fracture, tendon rupture. I fell and then I couldn't lift my arm. I went to lift up a box and then I had sharp pain down the front. I fell on my arm and my arm, it kills me, I can't move it. So you're thinking about structure, because that is then going to, again, you might go, okay, based on what you're saying to me and the limited amount of movement, the high amounts of pain, you might have a neck of humerus fracture. We need to get that cleared before I can do anything else. And that might be your treatment day one, and that's very appropriate. Sometimes it is appropriate to do not a lot, but a very good assessment and direct them to an appropriate care pathway. If it comes on gradually, then it's unlikely to be a fracture, or it could be a stress reaction. But again, different. Okay, if the mechanism of injury, so it came on suddenly, how did it come on? What position was their arm in? What structures are most likely to be overloaded? Are we talking about an arm across body position, which might be a posterior dislocation, or a fall out here, which might be an anterior, or it may be a fracture, or it might be a rotatoptic. But thinking about that mechanism to relate to the structures that might be most involved. Always stay vigilant to red flags. So while we talk about clearing red flags, we never actually clear red flags. They're always in the back of our mind, because if someone progresses along and doesn't get better, then you need to still be thinking about that. And sadly, red flags, including cancer presentations, can present as mechanical pain, and they can, in the early stages, respond well to manual therapy and soft tissue and exercise and things that we do. But they will then come back and the pathology is still there. And I sadly have had this experience with someone who had secondary cancers related to a skin melanoma, which he'd had 2 years prior, and he had bony metastases. So he came in with thoracic pain, he was clear, he had had his 2-year check, he was okay, and he actually had spinal metastases in his thoracic spine. He responded really well to manual therapy. He told me he had a job where he was lifting repeatedly in front, so an extended lever like this, and he ate through his back here. Makes sense, doesn't it? Responded well to manual therapy, his pain resolved. And this next time I saw him was when he'd come out of hospital and he'd been in hospital with a diagnosis of very advanced cancer. So I have missed it, and I feel I don't I don't know that I could have done it. I couldn't have done anything at that stage to change the course of his pathology, but it is good to recognise early if you can. But sadly, it does, red flags, always stay vigilant. They can present early as musculoskeletal pain, and they can respond well to manual therapy and pain relieving treatment. And often, if you are a first line practitioner, so people can walk off the street to come and see you, often their first thing will be they've got a bit of pain somewhere and they are looking for a reason for it. They're not thinking cancer, they're thinking they've pulled a muscle. So they come for your opinion. So we always have to stay vigilant to that. What are their beliefs around their shoulder? What do they think is going on? Because as part of your assessment, you need to work with that belief. You need to either prove to them that they're right, yes, you're right, Dr. Google was right, or they are not correct, this is actually what is going on. So people are very informed, aren't they? They go and check things out, they research online, they look for what their symptoms are, and sometimes they nail it, and sometimes they're completely wrong. You need to work with them to work that out. And what are their expectations of their treatment, like I was saying before? With their expectations, when it comes to your management, it's really important also that you outline what you expect their treatment pathway to be. Because people will come in expecting to be better next week, and they're not. Because we know that muscles and tendons and bones and rotator cuff, it all takes time to build and to build resilience and capacity. So if you don't set in their heads early that they're going to need that time, then they can feel that we're not doing a good job. In fact, we're doing a really great job. It's just that we can't make the body get stronger faster. So at the end of your assessment, I would challenge you to have a key diagnosis that you are working towards proving or disproving. You also have a couple of differential diagnoses potentially that you're thinking about as well. Have you identified the possible sources of their pain, their nociception? Have you identified the impairments and that are contributing to how they're presenting? Have you identified things outside, like their load or their work or their stress levels that may also be contributing to their clinical presentation? Because you need to be working with those as well. It's not just on the tight muscle, for example. And what can we change and what can't we? And if we go back to the example with the Olympics, we can't change that the Olympics is their events in 3 days. This is what we've got to work with. This is what we can do, and this is what we can't do, and we have to work with those factors. We're always working within a bio-psycho-social framework, and we have to weight those domains as to which is most important. With a fractured arm, there is a very high bio, for example. For other people, there might be quite a large psychosocial related to workplace pressures or sporting challenges or training stress or other things that you need to consider. But we are considering each of those domains and deciding for the person in front of you what is the most important, because that is going to help you decide which way that you need to manage it most in a prioritised way. So, this is our patient. Your clinical assessment begins when he walks into the clinic. So, I'll give you a little bit of background. He could be older, couldn't he? But he's actually in his final year of high school. So that's his age. What can we see if we start to look at our general observations? Now, I'd encourage you to be slow in your assessment. Don't rush into putting your hands on someone too early. Just look at them and see what you can get from the information that you can see in front of you. So, and we'll do this in a moment with each other. Generally, if you look at, and you are disadvantaged because you've only got one view and it's a just 2D back view, what can you see about his posture and his muscle tone and the bulk of his muscles? Is there anything you can see?
Left shoulder's higher.
Left shoulder's higher and the right shoulder's down. So at the moment you don't know which is his symptomatic shoulder.
Yeah.
So one's higher, difference of shoulder height. What else can you see? And just going for the big things, you know, don't worry too much about.
So we got the roof
So which way?
left side.
Left side that way?
No, what I mean is the fatty level at the left bottom.
Oh, are we talking here?
Yeah.
Yeah. So
Left side.
oh, sorry, here.
Yes.
Yeah. So he's actually quite muscly.
Yeah.
He plays a lot of sport. He plays rugby. He swims. He plays basketball. And he goes to the gym. So he's actually very muscly. But like you were saying, the curve of his muscles is different on his left to his right, isn't it? His spinal curve looks, you know, fairly straight from this end. Potentially, and it's difficult for you to see in that view, a little bit kyphotic and a little bit internally rotated, anteriorly tilted with his shoulders. You can't see in this view, and he's not. You can't see the inferior aspect of his scapula poking out the bottom. He's not anteriorly tilted, but he is a little bit kyphotic and a little bit internally rotated with his shoulders bilaterally.
And that's because of the gym training. Potentially. Likes his mirror muscles, speech muscles, yes. And also the work, you know, rugby, you have to be strong in that direction too, you know. He's a strong boy. So we're going to, just looking at him, that's what we've seen so far. Now, we're going to have a look then at his active range of movement. So you would routinely, for every shoulder patient, observe, look at their posture of those different structures, positions at rest, then look at euflexion, abduction, external rotation, internal rotation, and then if there's something specific to them, then look at that position. So for example, I treat javelin throwers. So when I look at all of their range and then I'll say, okay, get into your jav throwing position. And I come in like this and hold that shoulder like that. I say, do you feel anything particularly along that position? It might be hip tightness, it might be shoulder related. Look at the quality of the movement and where does the movement come from? So if they're moving into a flexed position, does it come from the glenohumeral joint? Does it come from the scapula? Does it come from the thoracic spine? Are they having to lean back a lot to get that upward end range of movement? So let's just have a look at our patient. So what do you think of his range of movement so far? Does he have good flexion range? Yeah.
Yeah?
But yeah, it does have his left shoulder is not abducting as much as the right one.
Yeah. So I don't know how much detail you can see. He's got quite good muscle around his scapula. If you look at the gap between his ears, though this one at the moment he is doing flexion, so you know he's got good range flexion, His left looks a little bit abducted compared to his right if you're looking at the space from his ears to his humerus. Because people who come up and do lots of movement with their elbow, you're interested in the humeral relationship to their ears, not their forearm. Okay?
So is that also part of the...
Oh, don't listen to me, I hate my voice here. Wait. Just ignore me. Sorry, what was that?
Well, is that also part of the scapula then? The fact that he doesn't have complete abduction?
We'll get to his abduction now. So if he then goes into, so that's his flexion range. And look, his left doesn't look as much range, does it? Oops, sorry. Let's go back. So flexion.
Is that popping out? No.
I'm giving you a little bit of information there. So that's his abduction there. So again, sort of looks like, if you look where his hands are, it looks like he has full range on his left, doesn't it? But the space between his humerus and his left ear is larger than the space in the humerus in his right ear. And we're looking in that position, you know, does his scapula upwardly rotate in a timely fashion? Sorry. And then we'll go one more. So we'll play it all the way through and you'll see his diagnosis at the end of this. So good range, nice thoracic extension there. It's not like he looks stiff through his thoracic spine as he comes up here. And then he goes out into abduction. And I've not cued him, I've just asked him to go out to the side. So there you go, there's his diagnosis. He's got an unstable right shoulder. So, based on what we know, the information so far, and I haven't given you a lot, which I'll fill in the gaps now. Age, we know he's late teenager, so hypermobility is still can be a significant part. Also, fascial injuries can still be a significant part in this age group. He's male, that probably not relating particularly too much to his presentation at the moment, except that males, teenage boys, will tend to throw themselves into physical activity at a very high level with not a lot of frontal thinking about it. So your risk-taking behaviour can be higher. They can put themselves in situations that put them at risk of injury, potentially more than females do of the same age group. His mechanism of injury. So at the moment, in this point in time, he goes to a school which has a lot of sport. He's finishing off his summer season of basketball, and that's where he had his injury, which I'll tell you about at the moment. He's also swimming for his school, and they're about to have their inter-school swimming carnival, which is a big deal. He's in his final year of school, so it's really important that he's participating. To him, it's really important that he's participating in this whole school event. He is also then overlapping training for playing basketball with the start of our winter season, which for him is rugby. So he is doing at the moment 3 sports. Each of them will have at least 2. Basketball will be 3 sessions per week, plus he's going to the gym. So his load is right up here. Now, he hurt his shoulder playing basketball. He went up to do a rebound, he was overhead, and someone contacted him from behind. Now, his shoulder didn't come out of joint. He had a feeling of instability and a feeling of discomfort, and he's experienced this before. So essentially at the moment, what would your provisional diagnosis or potential different other diagnoses be? What would be the maybe top two? Definitely shoulder instability. Which direction was it? Anterior. Is there another possibility? Multi-directional. So he has never actually dislocated his shoulder, but he has had multiple episodes of feelings of instability. And as you can see, he can come up, and I can't do that. I'm sure someone in the room can pop their shoulder in and out. So I'm sure we've got a few. So he has multi-directional instability. So at this stage, this is his first appointment with me. Does he need to have imaging at the moment? Who's yes? Who's no? Oh, okay. 4 no's, 5 no's, and many people, 6. Many people sitting on the fence. So, with the discussion around imaging, how would that direct your management? What would that change about what we were going to do right now? And when is it useful? So I just want you to have that thought bubble in your head. We're going to talk about it in the context of different clinical presentations. My answer for him right now is no. But when we come to shoulder instability, we'll talk about the cases when it would be a yes, when it would be a no, when might it be a later. Okay? A maybe. So we'll talk about that later. So at the end of that part, we have talked about the questioning that you would have done in a very clear, structured way. Every question that you ask should give you a piece of information. You know when you're first doing your undergraduate course and you get taught how to do subjective questioning, you have a list of questions to ask, so you ask every question. Do you know why you ask every question? And what are you going to do with that information? So that's what we want to do here. We're moving on from being new graduate physios to building our skills. Every question you ask should have a purpose that then directs you to the next question. And you don't have to ask it in the order that is on the list. You can move around and you can be fluid and be responsive to the person that you're talking to get the best information from them. Let them give you a lot of information to begin with. Just ask them an open-ended question and let them go for a couple of minutes. And you will hear what is most important to them. And then you can go, okay, and I'll sit there and type. And then I say, right, I need to go back and ask you a few questions about these parts. Or we've missed this, I need to ask about this. So everything you ask should have a purpose, which then takes you to the next step, to help you to start to rule in, rule out, and then gives you a prioritised approach to your clinical assessment moving forward. Treat the person, don't treat the imaging results. However, don't discard the imaging results either. And we'll talk about that too. So, in the end, generally they'll come with pain. Generally there's something that is bothering them enough that they're coming. Usually with pain. But it will also have components of these other things. They will either be talking about episodes of instability, too much movement. They may be talking about a lack of movement, hypomobility. They can't do the movements that they're trying to do. They can't tuck their shirt in. Or it may be they're lacking in strength, they're lacking in coordination, lacking in power. And that is going to be how you then start to direct the next step moving forward. So I think, morning Ted? That's 10:30? Oh, 10:45. Oh no, 10:30. I'm on, let's go with this one because it's a nice little break. All right, everybody. Actually, pause.